Metabolic syndrome itself does have a defining framework. Depending on who you talk to, there are a couple variants, but they all deal with the same subjects. Requires 3 or more, triglycerides over 150, HDL under 40, waist size greater than 40 for men or greater than 35 for women. The nice thing about that is for guys, it's mostly just your pant size. For women, there's some sort of crazy algorithm that I have no idea how to comprehend on how they do their dress sizes and things. But the point is you can measure it and use that as a term. It's easier than just a body mass index and such. The blood pressure over 130 over 85, and then a fasting glucose of over 100. So you're looking for 3 out of those 5. The caveat to that is if somebody is on cholesterol medicine, they already get 2 points because there are 2 lipid parameters on this set of diagnoses. Similarly, if they're on treatment for their blood pressure, that counts. So it's not so much that what their blood pressure is right then, you have to take into consideration whether they're being treated for it or not. So then the relevance. Why do we care about metabolic syndrome? Half the time you can't even really code that as an ICD-9 code. Nobody really understands it, doesn't have any billing concerns, and nobody goes around telling people when they get admitted to a hospital that they have metabolic syndrome. The point is, back to what Matt was saying about the screening. Who are you screening continuously for diabetes? Anybody who has metabolic syndrome has to be screened. 1 out of every 4 adults meets the diagnostic criteria by having 3 factors. 4 out of 5 has at least 1 factor is at risk. So you have to keep track of what their risk factors are and what their numbers are to determine whether or not they can wait until they're age 45 before you start screening them for diabetes every 3 years. If somebody's 35 and they have high blood pressure and they're on cholesterol medicines, you got to be following that person every year. Okay? Don't wait until they're 45 to start screening them for diabetes. They have all the red flags that are already there. So it's something that's worth keeping track of. Now, anytime you have a 3-dimensional graph, most people just zone out and ignore it. But in this case, just focus on the left side of it. Okay? Impaired glucose tolerance, and then your x-axis is the percent conversion to having diabetes as a diagnosis. So it makes sense that if you don't have impaired glucose tolerance on the right, you're probably not going to get diabetes. On the left side, though, in the back, if you have metabolic syndrome, much, much higher incidence of diabetes than just simply impaired glucose tolerance. So one would argue that if they have a diagnosis of metabolic syndrome, you can follow that as a bigger risk factor than just simply being in that gray area on your diabetes screening test. If they're between 5.7 and 6.5 with their A1C, yeah, they're at risk, okay? But if they have high blood pressure, high cholesterol, and so on, they're at bigger risk for becoming diabetic than just the sugars themselves. So the metabolic syndrome trumps simple insulin resistance in the diagnosis of diabetes, if that makes sense. So pre-diabetes. Sometimes you talk to endocrinologists and they say there's no such thing as pre-diabetes. Kind of like there's no such thing as pre-pregnant or almost pregnant or partially pregnant. You know, it's either you have it or you don't. I don't necessarily argue with that, although I'm pretty confident there really is a pre-diabetes category and that it serves a purpose. The same way that metabolic syndrome serves a purpose. It's a risk factor. You can treat it. You can prevent the incidence and conversion to full-blown diabetes, even if you're treating it the same as you would someone that has diabetes. So that's your gray areas. Impaired fasting glucose between 100 and 125. Impaired glucose tolerance between 140 and 199. What's not on the slide is an A1C between 5.7 and 6.5. If you're using that, and that's a new guideline. Like I said, 3 years ago, you didn't even use A1Cs for screening. 2 years ago, they said you could, but they didn't really tell us the numbers. And now in the last year and a half or so, they decided somehow with a magic 8-ball that's the range that they're going to call pre-diabetes. This is just an arrow representation of the exact same thing that I was saying before, if you prefer graphics. So who and where to screen? Like Dr. Dow was talking about, starting at age 45, that's the age to remember. It's kind of a pain to keep track of all these screening guidelines, but the reality is in primary care, that's what we do. When you're 50, you're looking for colonoscopies, and these are numbers that you have to memorize for screening purposes. You do it more frequently if they have any of the below listed items: family history, they're overweight, high lipids, high blood pressure, certain ethnic groups that Matt was also talking about earlier, vascular disease, prior glucose elevations, which includes being pregnant and having diabetes, then the gestational version, or history and exam findings, nocturia, polyuria, polydipsia, class 6 symptoms of diabetes. And if you look at this, that pretty much sums up metabolic syndrome. So it all goes back to my original point that these are people you have to screen before the age of 45. How to screen, we talked about that, so I'm not going to hash that out, kind of beating a dead horse. But again, focusing on which ones are the most sensitive. This slide actually changed. The second part, that this slide was something from our original presentation 3 years ago, so it's worth knowing that that is incorrect, that A1Cs are now accepted for screening purposes, but the point is still that they do have lower sensitivity values. Sensitivity, again, I know everyone's like epidemiology before lunch, tragic, but sensitivity is what's ruling it out. And so it has high specificity, lower sensitivity, okay? So if you don't screen, again, what's the point of all this? If you don't screen them and somebody is pre-diabetic, they have a 5 to 15% conversion to full-blown diabetes from pre-diabetes every year. So mathematically, they're not going to last very long in a pre-diabetic state. They don't convert in year 1, you have an additive risk in year 2, that eventually they will convert. It is inevitable that they will convert to full-blown diabetes.